Hello, everyone. In today's session, we're going to go through some secondary open angle glaucomas. We've gone through sort of ocular hypertension, primary open angle, and normotensive. And in today's session, I wanted to touch on the secondary open angle glaucoma. So we're going to touch on pseudo-exfoliation. We're going to talk about pigment dispersion, neovascular glaucoma, those related to inflammation, the lens-related glaucomas, and just a quick sort of run through of some different high-pressure states that you may come across either in casualty or even across other specialties. So we'll jump right in. With pseudo-exfoliation, you'll have come across this, at least in your reading. And the key thing to note here is that it's a systemic condition and it's systemic kind of release of this sort of dandruff-like material. It's associated with LOXL1 as a gene that's useful to know for your exams, and it tends to be found in either Scandinavian or Mediterranean populations. And actually, it's not necessarily the same sort of PXF. I think from some of the bosses that I've dealt with that see quite a lot of this, they tend to say that it can be a slightly different type of PXF when you're actually looking at these patients, with the Mediterraneans typically having more zonular issues, especially when it comes to cataract surgery, when compared to some of the other populations. But essentially, when looking at PXF, it's very easily missed. So it does require some very careful examination of the eye. And you'll most commonly sort of come across finding out about this either in listing somebody for cataract surgery, or, for example, they've had a dilated exam for any other reason. And what you'll find is this sort of whitish material that's being deposited on the anterior capsule that you can see in this picture. Some people will call it sort of like a triple ring sign, where you can see the central ring, this outer ring, and then the pupillary margin. But essentially, you've got this sort of circular deposition of this dandruff-like material. And then when you do some transillumination, you may also find some transillumination specifically at the peripupillary border. So it's usually right at the pupil where you're seeing this transillumination. And actually, when you're doing some gonioscopy as well, when you're investigating these patients, especially in the context of glaucoma, you may find what we call Sampelli's line, which there's a picture of on the next slide. Um, so this is just a sort of run through in terms of what you would kind of see on a patient with pseudoexfoliation. And today's session is talking about it specifically within the context of glaucoma. We'll have some sessions where we touch on this in the context of something like cataract surgery, for example. So PXF glaucoma is specifically when you've got a patient with pseudoexfoliation who also then has high pressures and evidence of glaucoma as well. You'll have patients with pseudoexfoliation, and up to a quarter of them may actually then progress to develop PXF glaucoma. And that's usually either due to pigment deposition at the trabecular meshwork blocking your angles, or it may actually be to do with your zonular dehiscence and anterior lens dislocation. So what you can see in this picture here is what we call Sampelli's line, and that's your sort of irregular pigment deposition along the angle, which it looks a bit different to the pigment deposition that you find in pigment dispersion glaucoma. And again, we'll look at that in a moment. And the glaucoma in these sort of patients can be much more difficult to treat. So you'll typically have them on drops. SLT does have a part to play in PXF glaucoma, but what the glaucoma consultants may tell you is that patients with PXF may have, rather than 360 degrees of SLT on the first sitting, you may want to do 180 degrees, because these patients are more prone to quite an inflammatory drive post laser, which then can cause a pressure spike, which may actually never come down. And the thing to consider when it comes to PXL glaucoma is that while surgery can actually be quite good for these patients, it does have a slightly higher complication rate, especially with trabeculectomies. But some studies suggest that the actual success rates are quite similar, but the complication rates can be a bit higher. With pigment dispersion, sometimes people kind of group pigment dispersion and PXF in the sort of same bucket, and they are different diseases. Pigment dispersion is an ocular condition. It's not part of a systemic condition. So with PXF, PXF is a bit more systemic. And actually, some patients with PXF, some studies have actually shown it's related to aortic aneurysms, for example, or valve disorders. And sometimes in some areas where they deal with a lot of PXF, patients are actually being sent for systemic workup. Whereas with pigment dispersion, you're looking at an ocular condition, and it's generally sort of thought as friction between your iris diaphragm, specifically in your sort of mid-periphery, with the zonules behind it. And that sort of rubbing releases the pigment from behind the iris, and that pigment then gets blocked up in the trabecular meshwork. And you'll find these are sort of associated with myopes, for example, so longer eyes, and more typically male patients, and you'll find these in the younger patients as well. One of the things that you may find in the history is, for example, with intense exercise, they then get this eye pain, and that's because the pigment is being dispersed and blocking the trabecular meshwork. And under close examination, again, you may find some pigment on the endothelium, also known as a Krukenberg spindle, or you might find some mid-peripheral transillumination. So again, a difference between this and PXF, your transillumination tends to be in that mid-peripheral zone where the zonules are rubbing against the iris compared to your transpupillary zone in PXF. And also when you're doing a gonioscopy, you may find pigment in the angle. But actually what's interesting is that you may find elderly patients in your clinic that are being treated for pigment dispersion syndrome, but actually if you were to do a gonio, sometimes the pigment starts to sort of settle down with age and you're not necessarily seeing it so much. And with pigment dispersion syndrome, again, so it can develop into glaucoma. It's not necessarily synonymous with it. And actually, PDS tends to be more likely to develop into glaucoma. And in some studies, up to half of the patients with PDS develop glaucoma. And what you can see on gonioscopy here is a more sort of heterogeneous, more of a homogeneous or homogeneous sort of deposition of pigment all the way across the angle. And again, this is also very difficult to treat and it can be quite refractive to treatment. You're going to be going up the same ladder with glaucoma treatment. And the SLT considerations are similar to PXF in that you may be careful with how much you apply on the first sitting and you may go for 180 degrees rather than 360. And again, with surgery, higher complication rates, but similar success rates with the operations. Then with neovascular glaucoma, this is a very different beast entirely. And what you have to remember with neovascular glaucoma is you need to really think about the fact that what's in front of you is an ischemic eye. And while neovascular glaucoma is typically thought of as an open angle glaucoma, it can over time, these fibrovascular membranes can essentially cause the iris to shrivel up right at the angle and actually eventually close the angle as well. So it can cause closed angle glaucoma as well. And again, like I said, even though we're talking about glaucoma in this instance, you need to consider the fact that it's an ischemic eye and you want to consider where that ischemia is coming from. It's typically an ischemic CRVO. It might be an ischemic CRAO or a BRVO. It may be a proliferative diabetic with ischemic retina. It may be ocular ischemic syndrome, and that's potentially life-threatening because they may have some carotid stenosis. It can be typical. Chronic retinal detachment can give you ischemic states, something like sickle cell, tumors. Essentially, the point of this slide is just to remind you that with neovascular glaucoma, you need to be thinking about the fact that you have an ischemic eye, and so long as that ischemic drive exists, your neovascularization is going to be um, propagating. So you want to try and control both elements of what's going on. And when you're coming to assess neovascular glaucoma, you're looking at the anterior segment, you're looking at the posterior segment, and then you need to think about what you're investigating for. So in the anterior segment, as you can see in this picture here, this is one of the patients that I came across in clinic. You can see some very clear evidence of neovascularization at the iris. You may find some neovascularization at the angle, and there's a picture of that later. Neovascularization in the angle is sometimes, even though you have to do gonio to find it, it's typically missed because people may not see neovascularization at the iris when they're looking at it on a slit lamp, but if you don't do gonio, you won't know that this patient doesn't actually has NVA. So if you're having a patient with a high pressure and you know they have an ischemic posterior segment, consider doing a gonio because you actually may find that the cause of the glaucoma is not just simple primary open angle glaucoma, but instead it's actually neovascular glaucoma, which is why gonioscopy is a essential part of your glaucoma examination. Because you've got this sort of neovascularization in the anterior segment, you're going to have some proteinous leak in the AC, which will give you some flare. You may even have a high femur as well. In the posterior segment, you're essentially going to see an ischemic retina, and you want to look for the cause of that. Is it a diabetic patient? Is it somebody with sickle cell? Is it someone who's had a central retinal vein occlusion? And you're then going to obviously assess the disc as well, because you want to know what extent of the glaucoma they've got. Then, when you're investigating for the ischemic state, the fundoscopy is a big part of that. You may want to consider doing an FFA or an ICG because that can show you capillary non-perfusion. It can give you the extent of that ischemic drive. Ultrasounds of the carotids if you're considering ocular ischemic syndrome. B scans, if you don't have a very good fundal assessment, or if there's a vitreous hemorrhage to help you assess the retina, you may even find some ocular tumors as well, and bloods as well. And that's again about seeing what the systemic state of the patient is. Either that's looking at things like blood sugar, for example, but also some hematological conditions can actually also give you these ischemic states. For example, profound anemia can sometimes present like this. And then when it comes to managing it, so before I go into that, if you look at this picture, you've got these very, very fine red vessels in the angle. And it's not this sort of, it's not always, incredibly obvious, but with good gonio, you can see them. And with managing neovascular glaucoma, it's directed at two things. So you'll find neovascular patients with neovascular glaucoma will typically be in a retinal clinic as well as a glaucoma clinic. And that's because the underlying cause of their ischemia needs to be treated. That's typically with something like PRP. They may have surgery, for example, to either reattach the retina or some endonasal, sorry, some endoscopic PRP. Or you may even consider applying something like an anti-VEGF, for example. And then you've got the glaucoma side of things with the pressure control. And that is very multifaceted. And actually, patients with neovascular glaucoma can be really, really difficult to treat. And sometimes it can be incredibly disappointing in that even with maximal treatment, these are patients who still progress very quickly. And even though you sort of treat the neovascularization at the angle, what you have to remember is, those vessels exist now, and even though they shrink and you're going to cause a lot of fibrosis, and some consultants whom, I've worked with in the past will basically say that if you've got someone with neovascularization at the angle and they have PRP to the back of the eye to treat it because they've got an ischemic CRVO, they're almost certainly heading towards having a tube surgery as well. So these are patients who are quite aggressive when it comes to the glaucoma side of things. You may want to consider giving them some long-term cyclopedia to help them with their pain. And lots of patients with MVG, unfortunately, do then progress to essentially having a painful blind eye, in which case you would be controlling pressure with things like cyclodiode, or even in dramatic cases, these are patients who are heading towards something like an evisceration. Inflammatory glaucoma, again, it can be both open and closed. So with your open angle glaucomas, these are patients either with acute inflammation. So for example, someone with a hypertensive uveitis. Patients with uveitis who are on long-term steroid drops can then have a steroid-induced glaucoma with high pressures progressing into glaucoma. And actually patients with chronic uveitis can then develop some scarring of the trabecular meshwork, or is that's the essentially theorized etiology of where this pressure is coming from. But patients with glaucoma, sorry, with uveitis can also then progress to have 360 degrees of posterior synechia, essentially completely occluding that pupil down onto the iris. The aqueous humor has nowhere to go, and then you get the pressure building up behindwards, bowing that iris forwards and actually occluding your angle. Or you may even have high PAS or peripheral anterior synechia as a result of the uveitis, and again, closing that angle as a result. So inflammatory glaucoma can give you both open and closed angle states. And there are a couple of syndromes. I have touched on this already in a previous session on anterior uveitis. You can find that in the kind of uveitis playlist, where I talk about Posner-Schlossman and Fuchs in more detail. So I'll just skip over that today. And then with inflammatory glaucoma, you're going to manage the cause of the inflammation. So that will be managing the inflammation of the eye, managing a systemic condition if it's related to that. And the surgical measures can be far less successful here. So things like trabeculectomies have a high failure rate in patients who are inflamed. And that's because that inflammation is essentially going to induce scarring on the ocular surface. And again, these are patients who are going to have joint care between glaucoma and the uveitis team. I wanted to put all of the lens-related stuff on the same slide because it can be easy to sort of forget what each word means. So having them just immediately compared to each other is, I think, the best way of remembering what actually each one means, because they do mean slightly different things. You'll see from this slide is the treatment, it might actually be the same, but in terms of the aggression of the disease and how quickly you need to treat something, it can differ based on the cause. So with phacomorphic, that it's just essentially it's a large lens. And you can usually see that because if you compare the two sides, one AC might be a bit shallower than the other. And it's, typically a patient who's either a hypermetrope with a very short eye and actually a very early cataract, or it's just a patient with a normal length of the eye, but with a good mature cataract pushing onto that pupil and causing pupil block. And Phacolytic is slightly different in that you have a very hypermature cataract, and actually, where the pressure is coming from, you've not got any pupil block, but you have these lens proteins seeping through, importantly, an intact capsule. And those lens proteins are very pro-inflammatory. You get a lot of inflammation in the AC, but importantly, that lens capsule is intact. Whereas if you compare that to phacoanaphylactic, these are typically patients who are post-trauma, for example, or foreign body, where you have a broken capsule, lens proteins and lens matter is seeping out into the eye, causing a massive inflammatory response. And then finally, with lens subluxation, either for patients with weak zonules for whatever reason or previous trauma, those lenses can fall, and they can be pushed forwards and again cause pupillary block. And essentially, what you're doing here is these patients eventually need their lenses taken out, and the speed at which you do that and what you do before depends on which one you're looking at. So, with your phacolytic and your phacoanaphylactic patients, these are patients whose inflammation ideally you want to try and settle. Now, phacoanaphylactic, you may not necessarily wait. These are patients whose lens needs to come out. Whereas with a phacolytic, you may want to try and control some of that inflammation before you go in, because operating on a hot eye is not always ideal. Phacomorphic, you can consider, doing things like giving them dilating drops and to try and prevent that pupillary block. But eventually, these lenses need to come out and be replaced. And with lens subluxation, these are patients who you're probably going to consider doing under something like a vitreoretinal list because they may need a different type of secondary IOL when you're actually doing the surgery. And then I just wanted to finally just touch on some different high pressure states. So, um, this is a quick sort of run through, but I'll talk about each one. So steroids in general, you'll hear the words, a steroid responder or a steroid response. And I think what I've sort of learnt is that roughly 20% of your general population will respond to steroids, which is why there's an argument to say that if you're starting somebody on steroids, it's wise to maybe bring them back for a pressure check, or at least let them know that they can try and get a pressure check from an optician, for example. Or if they're having any problems with pain, then it might be to do with the pressure if they're started on steroid drops for whatever other reason. And it's actually very important to then document very clearly that you are having a patient in front of you who is a steroid responder, because later down the line, for whatever reason, they may then be started on steroids, and then the pressure control is not given to them, and they're coming in with very high pressures. And patients who you're going to have on long-term steroids, you can consider therefore giving them low potency steroids instead if you don't want to have them on chronic drops controlling their pressure. So things like fluoromethalone, for example, fluoromethalone is not going to give you any problems with pressure. The problem with low potency steroids, though, is that typically they're also not very good at controlling intraocular inflammation. So while you've got patients who are on long-term steroids, let's say for ocular surface disease, those are patients who potentially would still get benefit from something like a loteprednol or fluoromethalone, and don't necessarily need high potency steroids like dexamethasone. But if you've got intraocular inflammation, sometimes you've got no choice. And therefore, these are patients that you simply have to give them the dexamethasone, but then just consider giving them steroid control, or even, I've seen patients who go on to have tubes to control their pressure because their pressure is just intractable with the steroid drops. Or if, for example, if it's a patient that you know is going to be on long-term steroids, then you may want to just nip it in the bud and consider giving them consider that a surgical kind of intervention earlier. Um, and especially if these are patients who are then going to have steroid implants. So, for example, someone with chronic DMO that isn't responding to anti-VEGFs, or patients with non-infectious posterior uveitis. Anyone who's about to have a dexamethasone implant in the back of the eye probably needs to make sure that they're A, not a steroid responder, or if they are, it's well controlled. Then with red cells, so this is essentially what it says. So you've got red cells in the anterior segment, usually as a result of trauma from a high femur, for example, causing problems with their pressure. But you do want to consider hematological conditions when you're treating these sort of patients. So while patients with a high femur and red cell glaucoma might be given things like Diamox, and actually just in general, when you're about to start a patient with Diamox, if somebody's got sickle cell in front of you, you want to kind of avoid them going into a painful crisis. So you do want to consider whether or not they've got something like sickle cell or a thalassemia before you start them on something like acetazolamide. Um, and then with ghost cell, this is again, it's essentially denatured red cells. So it's more from a posterior segment bleed, like a vitreous hemorrhage, with denatured red blood cells that have come forward into the AC and again blocking that trabecular meshwork. And that patient essentially needs a washout of the back of their eye. Angle recession is typically as a result of blunt trauma. You can see it on a gonioscopy, and these are patients who usually with angle recession then develop trabecular damage. Now, not everybody with angle recession is then going to have a problem with their pressure, and you might want to consider checking these patients' pressure slightly more regularly to begin with, but later down the line, they may then just have simply yearly pressure checks, for example, and if they're low risk, they may even have those in the community, and if there's any problems, they then are referred into secondary care. And what sometimes actually a lot of people fail to consider is actually the pressure can be coming from outside of the eye. So if you have raised episcleral pressure, you're not going to have the flow of your aqueous as you usually do because that relies on there being a pressure gradient between the eye and the episcleral vasculature. So if you have some vascular abnormalities within the episcleral area, you're going to have some backlog essentially onto the eye, causing a high pressure. Now that can either be from some vascular abnormality, something like a Sturge-Weber, for example, or you can even have abnormalities within the vasculature of the cavernous sinus, and these can also then backlog the pressure inside the eye. Tumors can cause high pressures. Now, either that's with an open angle of a tumor sort of pressing onto the eye, for example, causing you high pressures. But actually, also, they can importantly, if you have something like a melanoma at the angle or a melanoma in your iris, these can actually close the angles as well and give you a slightly different a source of the increase in pressure. And finally, just the last little syndrome that you may have already heard about. So with Schwartz-Matsuo, this is patients with chronic retinal detachments or even acute retinal detachments. You've got the photoreceptor outer segments that float into your anterior chamber and block your trabecular meshwork. Now, typically, this sort of pressure rise as a result of this does usually get treated quite well with just retinal detachment surgery. So, these are patients who might have a slight pressure rise. So if you're seeing a patient with an acute retinal detachment with a slightly high IOP, that may be why. So while you might control the IOP, once they have the surgery, you may find that their pressure actually gets controlled. Of course, there are other reasons why patients with retinal detachment surgery may then develop high pressures with things like gas, for example. But essentially, this specific syndrome tends to be treated quite well with the retinal detachment surgery. So just to summarize, we've kind of gone through secondary open angle glaucomas. So things where, you've got high pressures causing glaucoma on the back of the nerve, on the back of the eye, sorry, on that disc, with an open angle and the different syndromes that can lead to that. And the take homes here are essentially that lots of things can lead to an increase in pressure with an open angle. So you've got things that are ocular conditions, systemic conditions, things that are related simply to just glaucoma in terms of a glaucoma clinic, but also other conditions, so uveitis, patients with ischemic syndromes in the back of the eye. And there's lots of different mechanisms as to why the pressure in the eye may be raised. And that's why treatment can sometimes be more difficult because you're not treating a primary glaucoma. You're treating sometimes two different conditions. And the way that that pressure can therefore respond is a bit different because you don't have a sort of chronic high pressure, but you may be dealing with pressure that comes in waves. And considering that underlying cause and finding an underlying cause can really be quite crucial as to how you actually direct your management and what you can actually be explaining to the patient as to A, why they've got the high pressures, and B, from a prognostic point of view, knowing the underlying cause gives you an idea as to how aggressive this glaucoma might be, how difficult it may be to treat, and importantly, how early you're then considering these patients for surgery. In a primary open angle glaucoma that's controlled, you may be telling them as long as we're controlled, we don't need to consider surgery. But in patients with, for example, pigment dispersion, or especially I find uveitic glaucomas when I've come across them on my glaucoma firms, these are really aggressive patients. And you may be telling these patients that while we'll try and treat you with drops for now, it may be not long before we need to start considering surgery. And that's also sometimes because your patients are younger. And with younger patients, you're going to need to treat them for a lot longer. And that's why you may want to consider giving them more definitive measures earlier down, earlier in the line, with something like surgery. So I'd really appreciate your feedback, please. There's a link in the description as well if you're watching this online, or you can just scan this off the screen. The feedback is very, very important to me from a sort of understanding how to pitch these sessions, whether or not the people are finding them useful. So I would really, really appreciate your feedback. And thanks for joining, and we'll see you at the next one.